Our Community and Health Services Committee after the microphone is on. Welcome. Today we're going to be having a staff presentation on understanding drug use in Waterloo Region. Welcome to our colleagues from staff who are going to be presenting on that. I'd like to first call on Julie Hale to do the roll call.
Regional Chair Redmond.
Present.
Councillor Craig.
Present.
Chair Erb.
Present.
Councillor Foxton.
Present.
Councillor Harris.
Present.
Councillor Hunick.
Present.
Councillor James. I did see her around. I believe she'll be coming back. Councillor Liggett. Councillor McCabe. Councillor Nowak. Councillor Salonen. Councillor Shantz.
Present.
Councillor Williams.
Present.
Councillor Wolf. Present. And we have regrets from Councillor Burbanovich and Councillor Deutschman.
Thank you. As we begin this meeting, we are again reminded that many of our homes and places of employment in Waterloo Region are situated on the land that is the traditional territory of the Haudenosaunee, Anishinaabe, and Shonatan peoples. We recognize and deeply appreciate their historic connection to Waterloo Region, and we also recognize the contributions Indigenous peoples have made in shaping and strengthening this community. We are grateful for the opportunity to live and work here and reaffirm our collective commitment to keep the promise and the challenge of truth and reconciliation real and intentional in our region. Are there any declarations of conflict or pecuniary interest under the Municipal Conflict of Interest Act? None. We have no presentations, no delegations that we are aware of. So then on to item number 6, the consent agenda. If you wish to remove an item from the consent agenda, please indicate so now, as we'll not take any questions on consent items unless items are requested to be removed to the regular agenda. The items listed on the consent agenda will be dealt with in one motion. Is there any item that you wish to have removed from the consent agenda? Then could I have please moved by Councillor Wolf, seconded by Councillor Nowak. Could you please use your e-scribe buttons to vote? Councillor Harris and who are we waiting for? Councillor Craig? I'm in favor, my apologies. Okay.
Yes, I'm just getting into e-scribe now, so I'm a yes.
Okay. Councillor Wolf or Councillor Liggett, did she vote? Okay, thank you. That's carried. Okay, we're going to move on to 7.1, the Equitable Services and Opportunities, Understanding Drug Use in Waterloo Region. And Dr. Wong, our Medical Officer of Health, is online and is going to introduce the report, and then Rhonda Nichols and some of her colleagues will speak to it. Dr. Wong.
Thank you, Chair Erb. Good afternoon, councillors. So this report presents a snapshot of drug use in Waterloo Region using the latest and best available data. It also provides a high-level overview of local, provincial, and federal programs and initiatives to address high-risk drug use. While the local initiatives in the report have a focus on services that regional staff and public health and community services are involved in, Appendix C lists local drug strategy initiatives involving partners from across all sectors. The list in the appendix is much more comprehensive than what we would have been able to include in the report. Before I pass the microphone to Director Rhonda Nichols to introduce the speakers, I'd like to also recognize and thank Cameron Dearlove and Erica Poulin for being in the audience. Erica is the coordinator of the Waterloo Region Integrated Drug Strategy, also known in short as the RIDS, and Cameron is the new chair of the RIDS. in case you may have questions that they may be better able to answer. Thank you, and I'll now pass it over to Rhonda.
Thank you, Dr. Wong. Through you, the chair, good afternoon to you and Regional Council.
Just excuse me, is your microphone on?
It says it is.
Okay.
Yeah, okay. I'm here with my colleagues, Katie McDonald, Manager, Health System Integration and Strategic Partnerships, and James McIntosh, Acting Manager, Digital Health and Innovation, as well as Jonathan Mall, Manager of Substance Use Prevention and Past Manager of Harm Reduction. So we may be relying on him for some historical information should questions arise. We're going to talk to you, as Dr. Wong mentioned, around understanding drug use in Waterloo Region, and we're happy to take questions at the close of the presentation.
Thank you. So drug use is a complex individual and community issue. Addressing drug use requires partners across multiple sectors, such as public health, community services, healthcare system partners, non-government agencies, provincial and federal levels of government. Potential solutions for the ongoing drug use issue across Waterloo Region exceeds the capacity of any one organization. Drug use is not an issue exclusive to Waterloo Region. It's a national and global issue. We can do our best with the available data we have to work with organizations to better support those who need it. I'm going to move up to the next slide. We looked at the data to understand the who, where, when, and why of individuals who use substances. It is estimated that there are approximately 9,219 individuals in Waterloo Region using drugs, with most being male between the ages of 25 to 44. Self-reported data shows fentanyl and methamphetamines were the most commonly used drugs, and 55% of confirmed opioid-related deaths in the region last year occurred in indoor private locations. Next slide. Our 2023 paramedic responses to suspected opioid drug poisoning showed 1,449 calls across Waterloo Region, with the majority occurring in Kitchener and Cambridge. Data from the Office of the Chief Coroner of Ontario and Waterloo Regional Police Services have shown a steady rise in opioid toxicity deaths leading up to 2021, with a stable trend for the last 2 years. The two most recent years display probable opioid-related deaths from the Office of the Chief Coroner of Ontario and suspect drug-related deaths from Waterloo Regional Police Services. The timeliness of opioid-related death data varies by source, so we use a combination of the Office of the Chief Coroner of Ontario and Waterloo Regional Police Services data to provide the best available picture for Waterloo Region. To give a sense of timeliness, a confirmed opioid-related death takes between 3 to 6 months for the final autopsy report to be submitted, while the probable opioid-related death can take between 3 to 12 weeks for a toxicology result to come in. The suspect drug-related death data received from Waterloo Regional Police Services is the most timely, often arriving that same day. I'm going to turn it over to Katie, who's going to speak about root causes.
So people use substances for many different reasons, such as medical purposes, personal enjoyment, religious or ceremonial purposes, or to cope with stress, trauma, or pain. It is important that we view drugs from a broad, next slide, please. From a broad perspective that considers several factors. As mentioned by James, addressing drug use requires partners across multiple sectors. Comprehensive solutions also need to address upstream factors, which can include early life experiences, social determinants of health, and the individual's ability to access the supports needed. Downstream factors include substances themselves, such as how it's used, the level of toxicity, and how addictive it is. Next slide, please. As indicated in the Chief Medical Officer of Health's 2023 annual report, drug use requires an all-of-society approach, meaning it requires all levels of government, community agencies, citizens, and those with lived and living experience to work together. The challenges of meeting the varying and complex needs of those who use substances means that no one organization has the capacity or ability to successfully address these needs alone. We are one partner in a multi-partner response. One evidence-based framework that is used to address the current drug crisis includes the 4 pillars of prevention, harm reduction, treatment and recovery, and enforcement and justice. The foundation for the Waterloo Region Integrated Drug Strategy, working with several partners across multiple sectors, is a 4-pillar approach to substance use with an underlying principle of coordination and integration. A multi-sector, multi-pillar approach is key to addressing both upstream and downstream factors. Next slide, please. Public health's mandate to address substance use lies primarily within the prevention and harm reduction pillars, and public health also plays a role in data monitoring. Next slide. This slide lists some local initiatives where regional staff play a role. So, substance use prevention focuses on preventing or delaying the onset of substance use. Some of the initiatives that we have been involved in include partnering with both local school boards and local youth-serving organizations to discuss, prevent, or delay the onset of substance use. Harm reduction is an evidence-based approach keeping people and communities safe and minimizing death, disease, and harmful consequences of drug use and high-risk behavior. Public health's role in harm reduction, as mandated by the province, is lending support to service providers through programs such as the Needle Syringe Program, the Ontario Naloxone Program, and working to improve neighborhood safety, or the WINS program. We also support the work of the existing Consumption and Treatment Services site. Treatment and recovery includes withdrawal management, substance use counseling, substance use day treatment, for example, but public health does not lead treatment or recovery programs and services as they are outside our mandate. But we have helped onboard services into the Consumption and Treatment Services site, including the Rapid Access Addiction Medicine Clinic and the Ontario Addictions Treatment Centre. Next slide, please. I'll pass it over to Rhonda.
Thanks, Katie. As you've heard several times this afternoon, addressing high-risk substance use and associated harms in a community takes many partners working together. This slide here provides a snapshot of other services provided by other community partners and gives you an idea of the full spectrum of services available for people living with addictions in our community. Appendix C in the report provides greater detail on these services, and I would encourage you to have a look if you're interested in reviewing everything that's available. Again, it's really important to note that there is a difference between prevention, treatment and recovery, and harm reduction as you review this list. Next slide, please. We also wanted to share some context around federal and provincial funding envelopes related to substance use initiatives. The federal Canadian Drugs and Substance Strategy, guided by Health Canada, takes an evidence-based actions approach to reduce the harms associated with substance use in Canada. Between 2017 and 2022, the federal government committed $349 million to the Substance Use and Addictions Program, also known as SUAP, to support community-based organizations responding to substance use issues. Locally, this grant has funded both the Safer Supply Program and the CTS drug checking program offered by Sanguine. Provincially, the Ministry of Health provides 100% funding towards the provincial CTS programs, as well as many of the other harm reduction programs that Katie referred to earlier in the presentation. Not noted on this slide, but of equal importance, is the provincial funding provided for addictions and mental health treatment and services and supports provided to local health service providers in our community. Next slide, please. As we think about next steps, it's important to keep in mind the situation we are experiencing in Waterloo Region is unfortunately not unique. The unfortunate trends that we are seeing locally in the data are similar across the province. While each community does have its unique challenges in addressing this issue, the common thread is that no one agency is able to do this alone. As a local public health agency, we need to and we will continue to facilitate this all-of-society approach, which includes monitoring local data and providing this on our publicly facing dashboards to ensure this knowledge is broadly available, expanding our work with partners to develop new and enhanced upstream initiatives aimed at prevention, continuing to work with partners on our mandated programs, including those that Katie mentioned in the harm reduction envelope, and we will continue to support the work of partner collaboratives such as the RIDS, Waterloo Integrated Drug Strategy, which includes various health system partners as well. This multi-sector, multi-pillar collaborative effort, which is what you've heard about today, is the only way to address the issues facing our community. Thank you, and happy to take any questions you may have.
Thanks, Rhonda, James, and Katie. Are there any questions? Councillor James.
Thank you, through you, Chair Erb. Thank you for your presentation. Just a question on one of the first slides. You had numbers of the estimated drug users around 9,000. Can you explain how where that data came from?
Through you, Chair, Councillor James, the number that was provided there is from our needle syringe program. So that's the estimate that was captured by that program, and that's what we're referencing as users. We do feel it's probably an underestimate, and I think that's what was written in the report as well.
Yeah, I definitely think that that's an underestimate. And then in terms of benchmarks, was that, hard use drug users? Because I'm just conscious of when we put a number, when the realities are anybody who's taken a Tylenol and, had been prescribed anything, I mean, technically we're drug users. So I'm just wondering, what is the threshold for that from the information that determined that?
Very good. Through you, Chair, Councillor James, I would say that that number is reflective of the individuals who attend those programs, and those characteristics are ones that we end up reporting on.
Okay, thank you.
Councillor Shantz.
Thank you. Thank you for the presentation. My question is sort of along the same lines as Councillor James. I was looking at that 9,200 individuals and trying to think about upstream can mean a number of things, and we have a lot of upstream programs that we're using. But a lot of the overdoses happen in private residences and so on. So is there a place or a way to help people who are sort of just getting into being addicted? Maybe they've got a new pain or whatever. Like, is there some way to get at those? I know we've got acute people we need to deal with, but to me, that would be the place to catch a lot of them, perhaps.
Yeah, through you, Chair, thanks for your question, Councillor Shantz. I think that you're referencing the treatment services. So treatment and recovery is often where early substance use can be caught and can be addressed, which then prevents the more high-risk downstream substance use that we see, and that I think the data is speaking to. So when you think about substance use, there's a full spectrum. All of the prevention services that are offered, the treatment and recovery, and the high-risk use that we're talking about in our data is really those individuals that require the harm reduction services and supports in order to stay alive and well until they're ready and available, or ready and willing to engage in the treatment or the more upstream approaches.
If I could just follow up on that. So do we have enough support in that upstream sort of space? Or is it just a matter of people who are sort of in that space aren't ready to get help?
John, do you want to take this one? Through the Chair, Councillor Shantz, are you referring to treatment, or are you referring to the more upstream approaches related to addressing childhood adversity and early development pieces?
So I'm thinking of if I just had surgery, for example, and I'm finished my surgery, I'm finished all my drugs that were given to me, and I'm feeling like, you know what, I really need more. And because I know people who have gotten hooked that way, and so they go to street drugs. So are there supports there, or is that up to the individual to be cognizant enough of what's happening to go and search it out?
Yeah, through you, the chair. Generally, that is up to the individual to search it out or through their primary care provider in accessing treatment. So that would be the withdrawal management treatment services that you're talking about, which also has a continuum of services from community withdrawal management to residential withdrawal management. So people that are actively using and want to stop that behavior, it would be up to them to source those services out in the community through their primary care provider or another health service provider.
Councillor Craig.
Well, thank you, Mr. Chairman. I appreciate the report, and I think the facts that have come forward. The thing that bothers me about it, if we go back to 2018, we've essentially doubled in terms of the number of addictions, number of people using drugs every day. And I'm concerned that the next 2, 3, or 4 years, are we going to see that mitigated by the strategies we have in place right now?
Yes.
So through you, the chair, are you referring to the RID strategy or the full spectrum of services and the strategy around all of the different elements?
Well, I'm saying that in 4 years from now, and we look at a new report,
yes.
will it show a depreciation in terms of deaths and drug use because of the strategies overall that we're using today? Because that hasn't happened in the last 6 years.
Yeah.
I think Dr. Wong would like to respond if I'm...
Yes, if I may just add a couple of points. One of the points relates to the number that you were referring to, I believe, Councillor Craig, the 2018 number, which was also based on the number of unique users that access our needle syringe program. Because we don't have any other way to enumerate the number of people who are using drugs. And back then, the program supplied equipment for injection supplies. And now that program also provides inhalation supplies. So it's not quite an apples to apples comparison because that program is trying to get more people to come forward and more people to use its services in order to try to reduce the harms from high risk use. So it's true that the numbers have significantly increased, not quite an apples to apples comparison, but it is also a program that seeks to have more clients because we want more people accessing these services to reduce the harms related to their use. Now, one of the challenges that we do face that you have rightly noted is that there continues to be many people, who have addictions and who choose to use drugs in a high risk manner, and that we are seeing this increase, provincially, nationally, and it is something where all sectors and all partners are trying their best in terms of multiple ways to address use from all the way from trying to prevent people from using to trying to treat addictions and high-risk drug use when people want to stop. So the success of a strategy is dependent on things, obviously, as how successful we are in trying to reduce the harms related to high-risk drug use, but also it depends on the number of people who are using high-risk drug use. And we know that, that number, appears to be increasing overall. It's one of those things where we do have some statistics to show the number of people who access programs that reduce the risk, and those programs through research have been shown to reduce the harms. But I don't think that we'll be able to reduce to zero the number of people who are using or the harms with what we are with only the types of services that are available today, because we know that there are gaps and that we need more services. For example, we need more rapid availability of treatment services across the spectrum. Sorry, I was a bit involved, but thank you.
Well, no, I appreciate the comments, and I certainly agree with you about your last statements. I think, Mr. Chair, what I'm concerned about is we get these bulletins, 85 people have overdosed in a 10-day period, and 6 have died. Then we get another bulletin, about 6 more people dying in a 2-day period. And so I want to see that mitigated, and I'm looking for those kind of answers. If I can just continue just for a moment, I'm interested in the shelters. Do we have any idea of the percentage of people who are users in our shelters? I'm not trying to stump you here. I'm just asking.
I'm wondering if...
All I know is it's high. I'm just wondering if you have any more commentary.
Through you, Chair, Councillor Craig, I would say that depending on the data source that we have available, there can be some living arrangement characteristics. I wouldn't say it's something that we end up leaning on quite a bit when it comes to the reporting of some of the characteristics around opioid use. We talked a little bit there about the needle syringe program as kind of a measure of addictions, those using within the community. Within our dashboard, our drug use and opioid dashboard, there is a lot of information that we have from other sources that can talk about living characteristics, but they don't shed light on shelters. Some of it focuses, as the presentation mentioned, about indoor private locations. And that's something where we're able to get that picture for the community to use.
I'll come back in a few minutes, Mr. Chair.
Councillor Wolf.
Through you, Mr. Chair. Thank you very much for the report. I imagine you weren't surprised at your findings, since you deal with it all the time. With the 5 overdose drug-related deaths from June 12th to 17th, would you say that that's partly because our illegal drug supply is more dangerous than it used to be?
Through you, Chair, I'm wondering if Dr. Wong is still on the line to address that issue, that question.
Yes, thank you. Councillor Wolf, you are correct. What health units, public health agencies, that is, across the province are noticing is that the types of drugs and the combinations of drugs that are being reported, either being used or detected, by drug detection equipment, has become more toxic. That is one of the key reasons we believe that across Ontario and the country, we are experiencing a greater number of overdoses and alerts.
Okay. Thank you. In terms of programming, because we've got this poisonous drug supply, where do you see safe supply as part of our program? Or is it?
It's one program. You're correct. It's one of a few different programs. I know, again, Dr. Wong, I'm going to call on you to make a comment on safe supply.
Sure. So, Councillor Wolf, it is a type of program that is currently being assessed by Health Canada through their SUAP fund, as Rhonda mentioned. It is one option for treatment for those who have not responded to first-line treatments. But it is also something that requires more research to determine the applicability of it on a larger scale.
Thank you.
Chair Redmond?
Thank you, Chair Urban. Thank you all for not only coming to give us the reports, giving us the ongoing updates, and the leadership that you provide. I really think what we're trying to get at is how effective is what we're doing now, and where are the benchmarks? And it's always been my contention that government values what it measures what it values and changes what it measures. So this is probably a bit of a rhetorical question, but what would happen if we weren't doing all of this? Because I would agree with some of my council colleagues that these numbers are very challenging. You know, it's very saddening, and I know that there's a personal loss. I was looking at Appendix B, and even the deaths, some are suspected. It's not definitive. And I don't want to conflate two other issues that we're going to deal with, but you know, we looked at the wastewater surveillance and the fact that that was sort of an objective measure. Is there any sort of objective measure other than benchmarking against other communities to know if what we're doing is effective, and if we're doing something others aren't, if that's being effective?
That's an excellent question, Chair Redmond. Local public health agencies are given programs that they're mandated to deliver, like the naloxone program and the needle syringe program, usually based on evidence and you know, expert advice from the province and the feds. So usually that type of evidence about what is effective comes to us from the provincial government to enact in terms of programs. So that's one of the reasons that we put in place those programs. We also have some measures from the consumption treatment services side, which is operated by Sanguine and Kitchener, and that we support. That site produced a report, and it produces an annual report. And maybe even reporting on a quarterly basis to the Ministry of Health to demonstrate impacts. So yes, there are usually indicators that are associated with all the programs that we're mandated to deliver to demonstrate that these services are having an impact on reducing harms. If those services were not in place, I would say that the numbers we're seeing today would be much higher. That doesn't mean that we're happy with where numbers are at. It's obviously, it's an issue that continues to grow because of increasingly toxic supply and increasing numbers what appears to be increasing numbers of people who use drugs in a high risk fashion. So we need to continue to work together one of the things that partners do notice is that some of the interventions that we know are successful or that would be successful, we don't have enough of, such as treatment supports across the spectrum, which Dr. Nichols might be able to talk a bit more about if you're interested, but. We know there are a lot of people who would like to undergo treatment, but cannot, get it in a timely fashion, or cannot get the types of treatment supports that are best suited to them. So that's an area where, partners are trying to come together locally to address, but obviously we would we would benefit from more provincial funding in that area. Thank you.
Thank you, Chair. It looked like you were coming up to give additional information.
Through you, the chair, I'd be happy to invite up Cameron Dearlove of Porch Lake Counseling to speak a little bit further about treatment services and where the gaps are presently, if that's helpful.
Thank you.
Welcome, Cameron.
Okay, thank you. My name is Cameron Dearlove, recently become chair of the Waterloo Region Integrated Drug Strategy. And this is Erica Poulin, who is the coordinator for the RIDS. If you'll indulge us, we'd like to kind of put some context around the RIDS and give some information about who we are and some of the work that we've been doing and some of the planning that we're hoping to do. So first, we want to thank Public Health for inviting us up to speak to this issue and for preparing and sharing this report as it highlights for the community the scale and severity of the drug poisoning crisis we face in our region. A few things we want to highlight for Council from this report includes, of course, we've already talked about it, the number of people who are actively using substances in the region, likely over 10,000 unique individuals. So while the numbers in this report may be shocking, it's also important to point out that we have those numbers because they come from people accessing life-affirming health services, which is a credit to the work being done in the harm reduction space in this region. So the people who are accessing the needle syringe program, that's how we know how many people are using in the region. The importance of addressing root causes, including preventing homelessness. So that's one of the things that we really need to consider when we're talking about what does prevention look like, what does the downstream approaches look like. It looks like reducing and ending homelessness. It looks like making sure that youth have opportunities, that they have supports in place, making sure that we're really investing in our communities. It sounds like it might not be directly connected, but that's one of the major ways that we can mitigate this. And the need for an all-of-community approach to this issue. So as you've heard from the other speakers, there's not one agency, not one group that can actually make progress on this issue without a full all-of-community approach. However, on this point, we want to emphasize the extraordinary work being done by agencies and individuals in this community. The fact is that agencies and frontline workers are burning out. They are dealing with traumas. Through their work, some of the situations that they have to experience, they're amazing people who are doing amazing work in the community, working with people who use drugs and trying to keep people as safe as possible. I want to invite up Erica to talk about some of the work that the RIDS has been doing over the last couple of years.
Can you hear me? All right. So yeah, as Cameron mentioned, I'm going to go over some of the projects that the RIDS has been focused around. So recently, the RIDS pivoted to a project-based model instead of a pillar-based model to try to break down some of those silos. So some of the projects that are both ongoing from kind of previous days in the RIDS and recently. So the first, we've already talked about it today, but that would be the overdose monitoring alert and response system. So the committee that puts out the drug alerts that go to council, that is something that is co-chaired by the RIDS. So there were 6 community drug alerts issued in 2023, and then this year we've had 5 alerts and 2 extensions to date. And I want to just give a little bit of context, kind of similar how we talked about how the data collection from needle syringe program has changed. This year we've been able to do some refining of our process, so those aren't directly comparable numbers because there's not a exact formula of what triggered an alert in previous years versus this year. So one huge addition we've had this year is the drug checking program at Sanguine has allowed us to provide very detailed information about what is being seen locally in our supply at the time of alert. And it's been really important information that we've been able to give to folks that work with people who use drugs to say, right now, drug checking identified, for example, xylazine, which is an animal tranquilizer, and it's able to empower people to make make more informed choices about their use because we know the nature of the supply is constantly changing and unpredictable and increasingly toxic, all of those things we've spoken about today. So that's been part of the change in our alerting system this year that we've been working to integrate and find better ways to give that knowledge more widespread basis to the community so folks are aware of what's in the supply right now. An ongoing initiative we have is the Overdose Awareness Day events, so we will have 2 coming up again this year. This provides space for memorializing those who have been lost to preventable death. And this year's events, you can mark your calendars, it'll be the 21st of August in Kitchener and the 27th in Cambridge. The RIDS has also been doing some work surrounding various barriers that exist to calling 911. We know that there are a lot of parts of the 911 experience that for people who use drugs make it not actually necessarily safe to be calling 911. We know that people who use drugs can have very negative experiences when interacting with police, and that response is often attended to 911. So it's a huge factor in why folks don't always call 911 for that emergency medical care because of those safety concerns. So that group is kind of looking into how do we address that? And while we were doing kind of investigation around this topic, we also identified that a lot of times maybe someone who did accept transport to hospital for care, goes to hospital, has a really negative experience, faces a lot of stigma, and then they don't want to go back from that care. So right now we're doing work with both our harm reduction partners and all of the major hospitals in the region to look at how can we develop training for hospital staff to kind of improve the experiences of folks who do go on to get that care at hospital. Bigger picture-wise, the drug strategy is also involved in the Drug Strategy Network of Ontario, allowing us opportunities to collaborate with other drug strategies across the province and share knowledge. We have a lot of work going on right now regarding overdose monitoring and response and exploring how we can strengthen our response there. The RIDS has also been involved in the plan to end chronic homelessness, which I will spare you the details because I know you spend much time talking about that and are very familiar, but we're very excited to be involved in that work and see how we can integrate the needs of people who use drugs into that plan. We're also involved in the planning around the Waterloo Alternate Destination Clinic, as well as building relationships with both OHTs. We're also doing work internally, so that includes revitalizing our steering committee to make sure that we have accurate representation based on needs. Been doing some exploring on the path forward, which Cameron's going to get to in a moment. And keeping our website up to date, as well as connecting with public health units throughout the province to kind of keep a lens on the different policy updates that are happening provincially. So I will pass it back to Cameron.
So I'm here to talk as well about some of the planning that the RIDS will be working on over the next few months. But first, just wanting to address the question that was on the floor about what sort of treatment and recovery programs are needed in our community. And so I woid say the answer is all of them as far as enhancement and expansion. You know, so I'm also Executive Director of Porchlight Counseling and Addiction Services in Cambridge. We play a role, especially with people who are precariously housed or experiencing homelessness, in connecting them to supports, whether it's withdrawal management, if it is treatment programs, and then we provide some recovery living. All of these resources are heavily used in our community. The likelihood that we place somebody in a treatment program in our region is probably more often we are putting someone in a car and driving them to another community. That doesn't mean that there's not programs that exist here, it just means that they're full. And so we need to look farther afield to help people get the supports that they need. So, I mean, our staff are often, last week we drove somebody to Windsor. And, it's a really beautiful service that we provide as far as making sure that people get there, making sure they're picked up, and helping them with their ongoing housing needs. But at the same time, it's a limited support. That role that we play is not funded. That's not something that's a funded program. We just do it. And I think you'll find that, in a lot of these services, there are things that we just do because we know that these are needed. So, we do have women's treatment programs. We do have, the Men's Treatment Center in Cambridge that has a friendship built a few years ago. They exist. but it's not enough. Withdrawal management, for example, is one that we identified in Cambridge as a gap in that withdrawal management, residential withdrawal management exists at the Grand River Hospital in Kitchener. Most of the time, again, we're putting people in Brantford, Brampton, we're going to other communities. There just aren't enough beds, they're full, and so we have to look farther afield, or we have to wait until we can get a bed. Porch Lake, we run recovery living, so after somebody engages in treatment, typically residential treatment, but they don't have a safe place to continue their recovery living. In the past, or if they aren't part of this program, these are people that would probably go back to shelter, not an environment that's conducive to recovery living, and so that's why these recovery homes are so important. They've existed in our community. I think 2008 was when they were originally started. From 2018 to this year, we had no funding for these homes, and they were just sort of run on a shoestring that we've tried to manage. They've recently received some funding from the region through the Plan to End Chronic Homelessness, which is great news. But there's no provincial funding coming for these kinds of programs. So once again, it is something that we need here, and we're grateful for the support of that. But certainly, we'd like to see these kinds of programs enhanced. So we currently have, for example, a men's home and a women's home, a total of 19 beds. We could open 2 more homes and fill them up tomorrow, and we would still have a significant waiting list. And so that's, I would say anecdotally, without further research, that's what I would see as the state of treatment and recovery services in the region.
Councillor Foxon.
Thank you. I did have comments, but you've overwhelmed me. You've overwhelmed me in what you do, above and beyond. And I know it must take a toll. And I want you to know we're all really proud of you. We are, because you're fighting a war, and you don't have the weapons to fight it, all the weapons that you need. So we recognize that. Everyone in this room recognizes what you do. Interesting that the 55% that do it in the homes, and I'm not sure how we reach them. Maybe we need to put posters up and stuff, because Facebook and Twitter and all that other stuff is dying. It's not reaching the public anymore. The press isn't really reaching anymore. Maybe we need to hit every variety store and say, call 211 or call this number, just so somebody's on the phone when you do it. They'll ask no questions. There'll be nothing asked of you, except that somebody will be there to make sure you're okay. Maybe that's something else we could do if we could ever get funding for it, but you guys know the game well. But I want to thank you. I think you do an amazing job, and I think we would be in a lot worse situation if you weren't here. So thank you all so very much.
Councillor James.
Thank you, through you, Chair Harris. Just a question around opiate deaths in shelter. So I was looking at the Ontario Drug Policy Research Network, and they were stating between 2018 and 2022, the region of Waterloo had the 4th highest opiate deaths, and this was related to shelters, specifically those who were unhoused or precarious housing. I'm just wondering if, because we have our Plan to End Chronic Homelessness, that you all, especially with RIDS and all that, are part of the conversation in terms of our Plan to End Chronic Homelessness. Can you just confirm that?
Yes, so I personally was part of the co-creator group with the Plan to End Chronic Homelessness, and Erica with the RIDS joined that group as well.
Thank you.
Councillor Craig.
Well, thank you, Mr. Chair. Just a couple of things. And Cameron, I'm glad you're here because I want to ask you all the tough questions. Okay. But anyways, I was very much interested in the report dealing with the shelters with regards to the urgent public health needs sites, of which there are 3 in the region. Would your group be able to get some information on how they operate, how they're funded, who uses them, and if they have professional staff? I think it would be very interesting for regional council to understand that. Is that a possibility?
Yeah, certainly. UPHNS is an acronym. I don't remember what the, the actual words are, but it's essentially, you can imagine like a mini CTS. So it allows drug use in a specific location where there's an urgent need. So shelters would be an obvious example of that. Several shelters in our region have applied for and received that designation. I believe that's a federal designation that allows that to be put into use. And I believe that they can be perhaps a little more flexible as far as the supports. So for example, you saw in the report just how many people have died through inhalation as opposed to injection. Current provincial guidelines do not allow for inhalation services at CTS, which is a major barrier for 55% of the people who are using substances. UPHNS, that can be arranged, with an outdoor location or with modifications. And so that's, one area where there's some flexibility to actually provide that service for, in the way that the majority of people are actually using substances.
Yeah, I'd be very much interested in just the overall and how they operate, except to the things I've said to you. This is the last question. We report opiate deaths, but that's not the only ones. Am I correct?
Yeah,
I
that's
mean,
right.
we should be looking at the overall drug, I would say, deaths in the region. Can we get that upgraded?
So I would turn that over to public health for an answer.
Through you, Chair. Councillor Craig, so your question was reporting of deaths and that there should be a more...
Well, the number of overdose deaths related to drugs, not just opiates.
Okay. So the sources that we have up on our dashboard focus on opioid-related deaths. That's the source of information that we have readily available to us. And that's what we end up using to kind of present the picture for the community in terms of opioid-related deaths.
Yeah. Can we get the overall number, though? That's what I'm asking.
The only numbers that we're able to access are the numbers that are provided by the Office of the Chief Coroner of Ontario. So we're able to get the local numbers for our region, but they're the ones who determine what types of deaths that they will report on and the characteristics of those deaths. And as James mentioned, there's a little bit of a delay for those. So what we use in the interim before we get confirmed numbers from the Office of the Chief Coroner are police suspect overdose deaths.
No, I appreciate that. Thank you very much. Now, ladies and gentlemen, thank you. Okay.
I don't see any other questions. Thank you very much for the report, for attending. Thanks for the work you're doing. You're heroes in working in a very, very challenging environment. And I think it's important for all of us to remember that while the numbers in the report and that we're seeing with alerts are high, Waterloo region is not unique. It's happening all over, and we're part of a growing dilemma across the province and across the country. Thanks, Cameron, for stepping in to chair the committee. Good luck, and thank you all for attending. We are on to item 8, Council Committee Tracking List, which has been part of your agenda for information purposes. Is there any other business?
Thank you. Just could the tracking list be updated? It's got April 2024 for one of the things here, and so if we could just update it, please. Thank you.
So noted. Our next meeting is August the 13th, 24. I'd like to have we now need a motion to go into closed section. Moved by Councillor Foxton, seconded by Councillor James. Those in favor, if you use your e-scribe buttons. that a closed meeting of council be held on June the 19th at 5 p.m. in accordance with Section 239 of the Municipal Act for the purposes of considering and following subject matters, receiving advice subject to solicitor-client privilege related to a proposed purchase of land, and personal matters about identifiable individuals. Yeah, could I have a motion to adjourn? Moved by Councillor McCabe, seconded by Councillor Williams. Use your e-scribe buttons to indicate your support. And that is carried.